afternoon, ladies and gentlemen. You all are warmly welcome to the lunch symposium on the glycemic control in the era of comorbidities, clinical balancing act. I'm privileged and I'm honored to be the chairperson for this section. I'm in a great pleasure to introduce you the speakers, who is none other than Dr. Malik Mumtaz. Actually, we worked together in 𝗕𝗹𝘆𝗰𝗶𝗶𝗀. We were friends. We've been friends for more than 20 years already, but we haven't met each other. This is the first time that I met you again here in Myanmar. We worked together in 𝗕𝗹𝘆𝗰𝗶𝗶𝗀. So if I have a great pleasure to introduce, before that, I would like to thank to the audience for joining this lunch symposium. In particular, people from Cambodia, more than 40 people come to join to Myanmar symposium. I've been to Cambodia for twice. They have at the invitation to give a lecture 2 times already. So in return, I have requested Dr. Samsotha, and he has brought another Cambodian to bring here. So thank you very much for coming to join this symposium in Myanmar. IDEC, actually the name is MMDC, and as usual, from the direction it changed to IDEC. But my preference is rather than the IDEC, it should be the MIDEC, Myanmar International, to be a unique, but nobody dared to speak him back. So this is a shame for us, you know. So from the original aim to move to the another direction. Anyway, this is the way our life. So I have a great pleasure to introduce the speaker to the audience. We have a great pleasure. We are privileged to have renowned speakers from Malaysia, Dr. Malik Mumtaz, and he is actually very honorable speaker because, as we can see that his prefix name is Datu, Datu Dr. Malik Mumtaz, who is actually consultant endocrinologist and physician at the Island Hospital in Penang, and he is a visiting associate professor in medicine to RUMC. And if I have to read through all the CV, it will take time, so I just want to introduce you briefly to give more time for the speaker to discuss about the topic more lengthily, and for the question and answer second. Dr. Mumtaz actually his main research area of research is in diabetes, osteoporosis, and endocrinology. He was trained in Glasgow, where we met together. I work in Glasgow registrar, and he worked in the Glasgow in the nuclear medicine. And he has been in the primary or co-investigator in more than 50 research projects and international clinical trials. And he has published and presented extensively and contributes in regional and local CME activity. And he is the member of the Malaysian Clinical Practice Guideline Committee for Osteoporosis and Diabetes mellitus. And he was a council member and post-vice president of the Malaysian Endocrine and Metabolic Society. And he was a long-serving committee member of the Malaysian Osteoporosis Society. And as I mentioned, he was confirmed by the DSPN by the governor of the Penang in July 2018, which carried the title of Datu. So I have a great pleasure to invite Datu, Dr. Malik Mumtaz, to give a talk on the glycemic control in the era of comorbidities, clinical balancing. Dr. Datu, please. Dr. Datu Mumtaz speaks.
Okay, good afternoon. Thank you, Prof. Tint. Thank you, Myanmar Diabetes Association, Endocrine Society. Thank you to the organizers of this conference for the invitation, and of course, thank you for Servier for bringing me. It's been 20 years since I came to Myanmar. The last time I came was, exactly 20 years ago. So it's a pleasure to be back. Things have changed a lot. Now, what I've been asked to do today is basically talk to you a little bit about what the role of diabetes medications in this era of comorbidities. So basically, what you're seeing behind you is a beach in Penang, and that's the hospital where I work. This hospital is currently 600 to 800 beds, depending on whether they open up everything or not. It's a tertiary referral center, and it's a private hospital. These are my financial disclosures. So I am receiving honorarium for this talk. And this disclaimer basically says that whatever I say to you are my own opinion. It's nothing to do with the drug company or the organizers. So the highlights for today will be, I will talk about the extent of the problem, how big a problem it is, what legacy means, why we need to treat aggressively and we need to treat early to targets. We have to use the appropriate choice of medications, and we have to reduce the impact of comorbidities. And I'll talk about the comorbidities and where a sulfonylurea like glycoside MR fits in all of this. The extent of the problem is humongous. If you look at the world, basically, for every diagnosed diabetic, there is another person who is undiagnosed and doesn't know that he has diabetes. This is the same everywhere. So if you look at the numbers that are going to project in the next few years, you're seeing huge numbers of diabetes population, especially in our part of the world. In the Western Pacific, there is a huge explosion of diabetes. Malaysia is number one. In Malaysia, 20% of the population have diabetes. This is scary, which means that for every one person, there is another 20% who don't know they have diabetes. It is very, very frightening. And what is more frightening is that across the world, we are seeing HbA1c numbers that do not come down. So on average, in Malaysia, for example, only about 30% of the population treated for diabetes are actually below 7%. If you talk about 6.5%, then you can forget it. It's very, very, very difficult to get down to those numbers. In Myanmar, it's 6.7% of the population, and I guess you have about 2.3 million patients who have diabetes. So a very small number compared to the rest of Asia. And part of the problem is because the obesity epidemic that is seen all over the world. The first concept I want to introduce you to is the fact that we need to treat to target. Treat to target. The target is in HbA1c, and we need to achieve this number. So how well you treat someone now, or how well you've treated them in the past, will determine how well they do in the future. It's very, very important. This is the legacy effect. I'll talk about this in a little while. But the UK PDS study is the largest study ever done in diabetes. And what it was a 20-year study looking at a sulfonylurea and insulin-based regimen where the idea was very simple. They take newly diagnosed diabetics, give them medication, follow them up for a period of from 1977 for 20 years, and basically they said, look, would we make a difference? And what they did was from 1997 to 2002, up to 2007, they followed up these patients to see whether early intervention actually made a difference. And what they showed was that if you have patients who are treated properly in the beginning, you keep them to a level of HbA1c that is tight, you actually reduce complications, both microvascular and macrovascular, eyes, kidney, and even the heart. So good control early means that you prevent problems later on. It's not to say that you will not have problems, you will, but there will be less problems. So this is the message you need to tell your patients. When you see someone young who has diabetes, you need to tell them that, look, if I treat you properly now, you listen to me, you treat your diabetes with respect, you will find that later on, you will have less problems as you get older. The 𝗚𝗵𝗆 actually showed us that if you followed up these patients between the two groups, the intensive group, which received sulfonylurea, insulin, or metformin if they were obese, compared to what was standard of care in those days, and you followed these patients up for 10 years, at the end of the intervention period, you found that there was a significant decrease of complications of diabetes. And if you followed them for another 10 years, you found that you actually reduced cardiac complications. And this is important because right now, all over the world, we are seeing problems with comorbidities, cardiac, renal, which are associated with poorly controlled diabetes. So the early glycemic control basically allows you to project forward and to treat your patients in the future with less problems, and this is called the legacy effect. Legacy meaning that it's like you collecting money in a bank. You collect money now, later on, your children are happy because they have more money. But if you do not take care early or you do not save in the later part of your life, you will find that there will be a lot of problems. This is what the authors of the 𝗚𝗵𝗆 called the legacy effect. And this is something that we always have to remember when we are treating patients with diabetes. The other thing is that when you're treating someone with diabetes, you have to remember the earlier you start, the more benefit you give your patients. For example, if I diagnose someone with diabetes, where my cursor is here, oh, you can't see my cursor. So at the end, from diagnosis for myocardial infarction, if I treat early and I project it 20 years, I reduce the risk by 19%. If I treat 5 years after, it's 14% risk reduction. If I treat 10 years later, it's 6% reduction. So what you're saying is that no matter when you treat the patient, it's important. You are reducing the risk. But the biggest risk reduction is seen the earlier you treat. That's the message I'm trying to take and make sure that you are actually getting from me. Are we okay so far? Yeah? Postprandial hyperglycemia? Everybody's full? Falling asleep? No? Okay. Now, this plant that you see here, the flower, is actually Garliga officinalis, and this is the plant or the flower that metformin comes from, right? So, what are the targets for treatment? Now, you know why we have targets? When you follow someone up, right? And the HbA1c of 6.5, do you know why it was chosen? 6.5% and beyond is when you start seeing problems with diabetes complications. At 6.5% or more, you start seeing retinopathy. So they said that, look, if you want to prevent complications of diabetes, you need to make sure that you are below that threshold. And that's why this magic number of 6.5 came about. The recommendations are basically universal. Try and keep your patients below 7%. If you can, 6.5%, and you individualize. That means every patient you see, if it's an 80-year-old who has 10 years to live, you don't give him a 6.5, you will kill him with all your diabetes medicines. If it's a 20-year-old with diabetes, you want to be tight because you want to prevent complications. So you need to look at the patient in front of you and decide, what are the targets? What am I going to give this patient? What number? And that's important, right? In Myanmar, it's 7%. The rest of the world, it's, 6.5 to 7%. So basically, you tell the patient, I need you to be at this number for as long as possible, because the longer you are below this number means that you have less comorbidities or complications. Now, what are these comorbidities? We talk about obesity, cardiovascular disease, albuminuria, nephropathy, kidney disease, microvascular complications like eye, etc., hypoglycemia, weight gain. And what is important is that more than one of these will be in your patients, right? So the patient in front of you may be obese, he may have eye disease, he may have nephropathy, he may have heart disease. So when you treat someone, you need to look at the whole picture. Don't look at just the numbers. Take a history. Now, people with type 2 diabetes will have more problems than one. So if you look at this in blue, age more than 65, less than 65, light blue more than 65, you can see that the numbers actually, there's a laser pointer here. Okay, so you can see that the numbers, age 65 or less, there are multiple. So if you look at T2 diabetes, obesity, dyslipidemia, patients actually, a significant number will have this. If you look at, for example, type 2 diabetes alone in this population, maybe 9% in males and less. So it's very unusual to find diabetics with only one complication. They have a lot of comorbidities. And this is important because the more comorbidities you have, the more likely you are to die of this comorbidity, right? So this is, again, an important point, because more comorbidities lead to bigger problems in terms of CV mortality, renal failure, and so on. 1 in 2 Malaysians are either overweight or obese, and this is quite scary. So right now, you find that in a population which is having diabetes as a big problem, obesity is making its ugly head rear in terms of all these patients that we see. So obesity, diabetes, hypertension, nephropathy, retinopathy, all are big problems. And the prevalence of obesity actually is driving this epidemic of diabetes. Malaysia, Brunei, you can see Myanmar's 22.4%, Vietnam may be lower, Indonesia may be lower. So all across ASEAN, we are seeing numbers that are increasing. But in some countries like Malaysia, for example, the numbers are huge in terms of the obesity population. Poor control of diabetes leads to cardiovascular disease and other complications. And each 1% HbA1c increase, independent of diabetes, increases your risk of an acute myocardial infarction. So basically, CKD and HbA1c go hand in hand. And if you look at this Malaysian registry, for example, this is a group that presented to a hospital in Kuala Lumpur in Malaysia. And these are patients with acute MI, acute coronary syndromes. 50% had diabetes that were undiagnosed. So a lot of times, patients present to hospital with an alternative, with some other diagnosis, whether it's vision problems, whether it's neuropathy, whether it's chest pain, whether it's angina, and then they are diagnosed to have diabetes mellitus. This is the common scenario. And with diabetes, you have a reduced risk of, you have an increased risk of dying, reduced risk of lifespan, and the diabetics in Asia are more likely to develop CKD as well. So CKD, chronic kidney disease, is very common. And in Malaysia, for example, despite everything that we have done, we are still seeing a very high number of patients who go for nephropathy. So these are the comorbidities that we are talking about. And these are the challenges that we face as doctors when we treat our patients. So now, how do you treat? Are you okay with me? Still with me? No, not falling asleep yet, yeah? Okay, good. Now, how do you treat diabetes when you have so many comorbidities? It's a challenge. In the IDF 2025 guidelines, they talk about early intervention. So basically what I've told you, the legacy effect, the intervention, you have to treat blood pressure, you have to treat lipids, you have to treat everything basically. It's not only about the sugar, it's about everything. And sometimes patients cannot understand why they come to see you for one problem, but they go home with 10 different tablets, right? Patients cannot understand. But we know that we have to treat everything to mitigate that risk that the patients face. Education, lifestyle intervention, all very important. And when you have diabetes complications, we have to make sure that you have glycemic control, blood pressure, lipid, and you have to give them agents that are actually showing cardiovascular and kidney benefit. This is the mantra. This is what we have to do now as endocrinologists, diabetologists, when we see someone who has multiple problems. WHO says that in their list of essential medicines, they have empagliflozin, cana, dapagliflozin, you have gliclazide, you have metformin. These are the basic medications that we need to use to treat someone who has diabetes. And if you look at the recommendations now, in someone who has no complications or is low cardiovascular risk, you can use basically metformin with most things, right? If you have cardiorenal complications, then we should be using metformin, SGLT2 inhibitors, or drugs like semaglutide or even dulaglutide. I think semaglutide is available in Myanmar. So these are the drugs that we need to prevent that cardiometabolic, cardiorenal deterioration. And if they have no problems, basically, if they have no low cardiorenal risk, basically we can add an SGLT2, you can add a GLP-1 depending, and if they are obese, then you would use a drug like an SGLT2. I'll go through this in a bit more in the next few slides. But if they have cardiorenal disease, then it's very, very important to add an SGLT2 or a GLP-1 receptor agonist. So basically, there's a shift. Before, we had medications and we said, oh, the medication is to reduce your sugars. Now, the drugs that we use for diabetes are being repurposed to actually help with cardiovascular and with renal risk. So if you have someone who comes to your clinic in the beginning, you'll find that, okay, combination medication, sometimes you need to give metformin with another drug because combination makes a lot of sense. You bring down your HbA1c faster. If you cannot, despite the patients being compliant to medication, you add another drug. You add another drug. You never remove. You add. And you keep adding until such time that you say, well, I'm sorry, but we need to use insulin. So this is the concept. And you try to use whatever in Malaysia, we have this algorithm here, which says that if you start with a HbA1c of, let's say, on the extreme, this side, on the extreme right, HbA1c 6.5, fasting glucose is low, you can use anything. Metformin first, as first line, and then you can use sulfonylurea, anything, DPP4 inhibitors, and so on. And as you move down towards the end, the other side, the HbA1c gets higher. So you use combination drugs, you may use insulin, and so on. This is in our clinical practice guidelines, basically. So we use, basically, you know that every single medication you use will lower your HbA1c by only about 0.5. Maximum, if you're very lucky, maybe 1%. If you are at 14 and you need to be at 6, one medication is not going to work. So that's why you need to consider combinations or even insulin. In Myanmar, metformin is used first line, and then you add sulfonylureas, combination therapies, and so on. So again, very similar to what we do in Malaysia. Now, when you bring a patient back, after 2 or 3 months. You do not wait and wait and wait and wait until the patient, 10 years later comes back to you and says, oh, doctor, my sugars are still not controlled. Bring them back within 3 months. And if you're not achieving targets, you add a second drug, you add a third drug, and you may want to avoid the inertia. This is called treatment inertia. As doctors, we want to treat, but we don't want to treat, but we don't want to give insulin because the patient may not come back. This is called inertia. And we need to push forward and make sure that we are actually getting to where we should be. Reassess HbA1c after 3 to 6 months, and then decide what do you need to do. If they're not achieving it, then start all over again and push for more medication. Now, after the patient comes back, you ask yourself, does the patient have heart disease? Does the patient have heart failure? Do they have diabetic kidney disease? Do they have hypoglycemia? Is weight gain a concern? Is cost a concern? Is there a change in socioeconomic status? You give someone a drug like a GLP-1 receptor agonist, then 2 months later the guy loses his job. He cannot afford the medication. You need to assess all of this when you see them. And then you reassess. Now, then the algorithm changes. So if your patient is, let's say, obese, right? If the patient is obese or overweight, and you're trying to achieve weight loss, then the drugs you may use are actually GLP-1 receptor agonists or SGLT2 inhibitors. If you have someone who is at, for example, high CVD risk, the data supports using dapagliflozin, canagliflozin, or one of those SGLT2 inhibitors, as well as the GLP-1 receptor agonist. So basically, where your patient sits is what determines the type of medication that you will lose. The ADA guidelines are very clear. If you have, for example, high cardiovascular risk or kidney risk, then you need to use a GLP-1 receptor agonist, as well as an SGLT2 inhibitor. These are the drugs, and I saw outside you've got many of these examples in your country. So these are the drugs that you should be using to try and protect your patient. So now, is there a role for sulfonylurea? So far, I haven't actually mentioned sulfonylureas, right? All the guidelines all say SGLT2, GLP-1 receptor agonists, and so on. So in this era of comorbidities, is it necessary? Is it safe? Should we use sulfonylurea? Now, the advanced study was a large study carried out on 11,140 high-risk patients, and they randomized them to 2 groups, basically looking at diabetes control in a population that was newly diagnosed, but a shorter period, and they also looked at blood pressure control. So the mean age of around about 66 years old, and what happened was the design was factorial. So they randomized patients to receive blood pressure control, diabetes control, and so on. I don't have time to go through the advanced study, but this is a landmark study. And what it did was, it told us a lot of things. You see, in a lot of situations, we try to get down to target very quickly. In this advanced study, they took 2 years, and they brought their patients who were in the intensive group down to 6.5%, and they actually showed significant benefits. There were substantial reductions across all subgroups, and this was over a 2-year period. In some of the earlier studies, it went down very, very fast. In the VADT, in the ACCORD study, and so on, they went down like that. And what happens? Patient had more MIs, patient had problems associated with treatment. With this, it went down over a 2-year period, and there was actually very little problem. Now, what it actually showed was there was actually a reduction of nephropathy that was demonstrated in the advanced study. So microvascular complications even went down, even in a short period. So in a situation where you're using some of these current medications, using sulfonylurea like gliclazide MR will not do any detriment or harm to your kidney. In fact, it may actually help your nephropathy. Hypoglycemia, which is another big problem, is minimized. In Malaysia now, we still use a lot of glibenclamide, and we see a lot of problems. WHO now recommends actually above 60, you should not be using glibenclamide, especially in the setting of nephropathy. So in the setting of advanced, they were shocked when the data came out at how low the rates of hypoglycemia were in terms of the population that they studied. And the VADT ACCORD actually showed significant levels of hypoglycemia, as shown in this slide here, with glimepiride particularly. So gliclazide weight neutral, there wasn't a very significant weight change, which is again important, especially when you're treating an obese population and you're telling them, look, I need you to lose weight. I need you to lose weight. And then you put them on intensive treatments like insulin, which help them gain weight. So glycoside MR, again, is weight neutral. The CV safety of sulfonylureas as well has been proven by advanced and other studies as well. So it's actually safe to use a sulfonylurea in that setting of comorbidities and CVD. So in essence, you can use most of these drugs in combination with the sort of recommended glycoside, with the GLP-1 or the sulfonylureas and the other things quite safely without increasing problems. And if you look at advance and advance on, what happened was after the advanced study finished, there was an initial significant drop of 6.5% in the intensive group. And in the intensive group later on, they actually climbed back up when the study finished. But what was interesting was that the benefits of glycemic control actually helped even in nephropathy. So there was a reduction in terms of end-stage renal disease reduction and progression even after the intensive treatment finished. This is more like a legacy effect. So basically, all the studies that have been done on intensive control, whether it's the STENO study, whether it's the UK PDS, all show that if you are good early on, later you benefit from all the intensive treatment that you had early on in life as your diabetes. The other interesting thing is that, what happens is that when you are on treatment, this was a study done in Thailand, and what they did was they had long-standing patients, long-standing diabetes, on insulin and sulfonylurea, and they withdrew the sulfonylurea. Small study, but they actually showed that there was worsening of glycemic control. And we see this in practice. So in reality, sometimes when we need to get good glycemic control fast, we use a sulfonylurea. And withdrawal of that sulfonylurea is perhaps something that causes the glycemia to get worse. The only situation where you have to be really a little bit cautious about is when you're using high doses of SGLT2, insulin, and so on, and you add or withdraw the sulfonylurea. The sulfonylurea sometimes can cause a big drop, especially when you add an SGLT2. So in that situation, sometimes we need to reduce the dose of insulin we give because we don't want to cause hypoglycemia. You can increase later on. So you remember, you're dealing with potent drugs that actually are very, very effective in lowering sugar. So you need to be careful when you're combining these medications. There is a synergistic benefit of sulfonylurea and SGLT2. And we know this. In practice, when you are on metformin and SGLT2 and you're still not achieving control, we actually see great benefit when you add a sulfonylurea like glycoside MR. This is standard. And even in my practice now, if I see patients or I've given them several medications and I need that little bit of extra drop or whatever of HbA1c, a sulfonylurea like glycoside MR will do the trick very, very nicely. You with me? Yes? Okay, good. Now, so what we've discussed is basically, I've told you that the diabetes problem is humongous. It's huge. All across the world, in Southeast Asia, we're seeing more and more patients with diabetes. The healthcare, the Ministry of Health cannot cope with the numbers that we are seeing. Legacy effect is important. So you need to treat early, treat aggressively early on to see benefits later on. And this was shown by UK PDS, Advanced, STENO, whatever, all the studies that actually have shown this. So basically, when you're treating someone with diabetes, use appropriate medications. If they have heart failure, use an SGLT2 inhibitor. If they need to lose weight, you should consider using a GLP-1 or an SGLT2, whatever. There are guidelines that tell you that in specific situations, you need to use the right kind of medication. What I've shown you is that even despite having all these kinds of medications, adding glycoside MR will do you no harm and will do you no wrong, because it will still basically allow you to safely bring down the sugar in the era of all these comorbidities. And remember, you have to respect each comorbidity. The lipid, the hypertension, the what have you, all have to be treated on their own merit. So with that, I would like to thank you.
You all have just finished lunch, and you all must be now getting choosing. Is there any questions? Professor 𝗕𝗹𝘆𝗰𝗲𝗺, she is right now currently the president of the Myanmar Diabetes Association. I have founded the association, but now I have handed to my senior colleagues. She is Professor 𝗕𝗹𝘆𝗰𝗲𝗺, lifelong diabetologist, renowned diabetologist. Professor 𝗕𝗹𝘆𝗰𝗲𝗺, please.
First of all, I'd like to thank a very informative talk regarding the diabetes management. Our situation is rather the same as yours. So the patient have to pay out of their pocket usually. So after first step is metformin, and sometimes we want to use SGLT2 because the patients are maybe weight according to the weight. At that time, how do you judge? How do you explain to the patient if there any financial constraint, if the patient think this is expensive, and he or she like to have less expensive one, like sulfonylurea? How will you judge how do you assess the cost benefit? How do you explain cost benefit to the patient? Because sometimes patient will just say expensive, don't want to use SGLT2. So we just give the sulfonylurea. But for the patient, if there's a high risk for the cardiovascular and cardiorenal, we like to add the sulfonylurea. So in these choosing the two kind of next step, how do you practice? Just your experience.
Thank you for that question. Actually, the situation is this: I work in a private hospital, so I'm in private practice, and most patients who come to see us in the private practice already expect to pay, so that's not an issue. But you have to realize that not everybody is going to come and end up seeing you in private practice. So like you in Malaysia, we have a huge number of patients who go to the government hospitals. And these are the patients who are not willing or cannot afford to pay out of pocket. So the guidelines are very clear. And if you look at the American diabetes guidelines, they look at even the Malaysian guidelines, there is a section there that talks about cost effectiveness. So in patients who cannot afford the more expensive medicines, it doesn't mean that they cannot get medicine. And so sulfonylureas, metformin, etc. are good choices for these kinds of patients, right? However, if you have a patient who needs the other medications, for example, the SGLT2 inhibitors, there are generics. While I don't encourage generics generally, because if you go by clinical trial data, they all use the original drug. But in reality, not everybody can afford. So there are good generics out there. And I think these are a reasonable compromise, right? So that's the approach that I would take. Whenever possible, I would use the drug. If they cannot afford it, then I would offer them a generic or alternatives to that generic, which would be on the column that if you look at ADA or even the Malaysian guidelines, there are alternatives. So sulfonylureas, etc. are the alternatives. But you must remember that you need to counsel your patients properly about, for example, when using a sulfonylurea, especially in the setting of insulin or whatever, there may be a slight increased risk of hypos and that kind of thing. So you need to counsel your patients. But most patients, generally speaking, I think will be willing to spend a little bit of money if you can counsel them about potential benefits of treatment.
Thank you.
Yeah.
Thank you. It is very important because in this era, our approach is patient-centered approach, which means that we need to take into consideration of the patient wishes and what do they want and what are the evidences. And we need to make a compromise between the guideline and the patient wishes. Unless the patient wish to cooperate, the adherence is definitely low. no matter how hard you're trying to prescribe the best of the drugs, they won't follow you. So it is, the explanation is very important.
You know, it's quite interesting. What has happened in Malaysia, for example, is that if you asked me 10 years ago, would I use 4 oral anti-diabetic medications, oral glucose-lowering drugs, before I consider insulin, I would have said no. But our current guidelines takes that effect of knowing that if I give the patient a metformin, if I give them a sulfonylurea, I give them an SGLT2 inhibitor and a DPP4 inhibitor, 4 drugs, right? I actually have that option of adding a 4th drug, which is the SGLT2 inhibitor, and the patients avoid insulin. So patients rather go on 4 different medications, take a whole handful of medication, rather than go on to insulin. So this is something that, as we said, we're talking about patient-centric now. The patients now dictate, because they will tell you, you give me the insulin, no way in hell am I going to take the insulin. I'd rather you give me many tablets, it's okay. And whenever possible, you know, in these types of patients particularly, using a sulfonylurea makes a big difference, because the sulfonylurea actually drops your sugar very quickly. So it's important, that's why you need to counsel your patients and see what they want. Otherwise, they're not going to come back and see you.
Thank you. Actually, I'm one of the authors of the global guideline by WHO for the first metformin, second sulfonylurea, and then what is the third line agent. When we write that agent, it's a consensus that that choice should be insulin, because the evidence for the GLP-1 and the SGLT2 and even the DPP4, they are not very strong at that period. So according to the guideline, the first is metformin, second is glycoside, and the third is sulfonylurea. Now it should be changed. I have pointed out that we should change the guideline. So we can add either SGLT2 inhibitors or other ones. So it changed with the time. Now Professor 𝗕𝗹𝘆𝗰𝗲𝗺 is a renowned nephrologist, most senior nephrologist in this country. The floor is yours, Professor.
You were just mentioning about the comorbidities, and being a nephrologist, you know, whenever we are facing the diabetic kidney disease patients, according to the latest 2024 KDIGO guideline, SGLT2 inhibitors are the first choice of drugs, followed by GLP-1 receptor agonists. The issue is SGLT2 inhibitors are good in reducing proteinuria and anything, renal protection, but in reducing, getting the reducing the hyperglycemic control, it is still not sufficient to give SGLT2 alone in our practice. So since metformin is out of question, we still have to use sulfonylureas in addition to either the SGLT2 inhibitors, because GLP-1 are very expensive, and although it is available, very few patients can afford the GLP-1. So what do you think of that?
No, I totally agree with you. I mean, as you get down towards CKD class 3, going down to 4, your use of metformin, most guidelines will say above a creatinine of 200, you're not going to use metformin anyway. And most patients come in and they tell you, look, I don't want metformin because ChatGPT said I cannot use it. So you cannot use it, so they don't want metformin. So then you're stuck. You need to give them a SGLT2 because that's what is recommended in terms of renal protection. Then you're left with not much. You're left with insulin, which most patients don't want anyway, and sulfonylureas. And sulfonylureas are safe to use, even in lower renal status. So yes, I totally agree with you. I think sulfonylurea, glycoside MR plus SGLT2. Sometimes we may use things like acarbose, or you have voglibose here, and that works quite well as well. I'm not a big fan of using acarbose or voglibose because patients tend to pass a lot of wind and all that. But in patients who are on these kinds of medication, when you withdraw, the sugar goes crazy. You know, so nowadays I've learned, as I get older, I learned don't mess, if it works, don't mess with it. So if they're already on acarbose and they're stable, I usually won't remove it. You know, that kind of thing. So yeah, I agree with you.
And the other part is the post-transplant diabetes patients, because we do have a lot of these patients. And again, with the post-transplant, provided the renal function is okay, we tend to use metformin. or sulfonylureas, because SGLT2 inhibitors, although they are still not in the guideline for the post-transplant kidney transplant patients. So
I think post-transplant is, I mean, you expect their renal function to be quite reasonable.
Yeah.
So the only problem will be whether your medications are going to interact with the immunotherapy that you're giving.
That's true.
That's about it, I think. So, yeah, I think you're quite, I would totally agree with you.
Okay, thank you.
Yeah, Professor Miha.
So I am taking the chance of presence of the nephrologist as well as the honorable guest speaker here. So we are talking about chronic kidney diseases, and I learned from the speaker that sulfonylureas can be used still in the chronic kidney disease.
Yeah.
And also the SGLT2 inhibitors in the chronic kidney diseases. So how safe are the sulfonylureas and SGLT2 inhibitors in very advanced chronic kidney disease?
Okay, so SGLT2 inhibitors, if I remember correctly, less than 30 mils per minute, you probably will not use an SGLT2 inhibitor. If you're starting at a higher level and the patients down, they slowly, progressively get worse, you don't remove. But if they're already down below that level, you're not going to add, okay? So they're not going to do any harm because the SGLT2 inhibitor works on the premise that you have kidney function. So if the kidney is not working, it's not going to work that well, right? So if you're starting high and you get lower, you don't remove, but you don't start if they are actually low. Now, in terms of sulfonylureas, generally speaking, they're quite safe to use until about a GFR of around about 30. So once they go down very low, you have to be a little bit more cautious with hypoglycemia. But with glycoside MR, generally it's quite safe. The one that you worry about is glibenclamide, whereby even a slight renal impairment, the metabolites of the sulfonylurea, the glibenclamide, stay in the body for so long, and you get prolonged hypoglycemia, right? Okay.
Okay, thank you. Professor Kisota?
I see things are warming up here. Okay, let's go.
Thank you, Professor, for your very informative talk.
So
my question not directly relate to your topics, but because you highlighted the important point to start the treatment early so that we can prevent the complications and even the longevities can be increased. So I want to know, in your country, are you doing the prevention of the diabetes? Screening of the diabetes and detection, are you doing this practice and implementing, and how you are doing? Thank you.
So your question is, sorry, I didn't get that.
The screening of the diabetes in the public to detection of the early because as you know, all the data showing that we detect very late. Even if you detect, only the 50% of the patients are getting the right treatment.
Right. Okay. Our mantra as physicians should be prevention better than cure. Because once you get diabetes, treating is a nightmare. As you know, it's so difficult to treat someone who has diabetes. So it's better to prevent. So how do we prevent? It's diet, exercise, and sometimes we use metformin and other medications, okay? So the philosophy is changing slightly in that there was a study called the VERIFY study, okay? And VERIFY looked at vildagliptin. And what they did was they started treatment at levels of HbA1c of 6.5 or around 6.5, 6.2 to 6.8. So these are the types of patients who traditionally I would have said, you go back and exercise, you go back and diet. However, we gave them medication, they gave them study. And VERIFY is the first study that showed that a combination of metformin and vildagliptin actually prevents progression towards insulin, better outcome, faster reduction of HbA1c, and greater sustainability. So while our philosophy should be diet, exercise, don't let your children watch so much TV, don't give them handphones, take away the PlayStation or whatever that they're doing, make them go out and exercise to prevent that diabetes. Sometimes some patients benefit from early intervention. So this early intervention can be metformin, can be a combination of the DPP-4 inhibitor plus metformin. Discuss with the patients, that's what I do. Some patients will say, doctor, I've tried my best, I cannot. Then I want medication. So fine, I give them medication. Some of them will say, okay, I'm going to start jogging, I'm going to do this, I'm going to do that. And I'll see you again in 3 to 6 months and we decide whether I need. So it's very different. So individualize it based on what your patient wants. But generally speaking, lifestyle changes should be your mainstay of treatment for someone with pre-diabetes or borderline diabetes.
Okay. Dr. Sedante, he's a pediatric cardiologist, pediatric endocrinologist.
Patients, yeah. We have increasing numbers of the obesities in the children, or some children has that very severe features or insulin resistant and fatty livers and obesity. When they came in high hemoglobin A1C also like 9, 10, 11. So I started the lifestyle modification as the mainstay of treatment. And my question is about the regarding giving all the medications, especially at the children's and the adolescent age. So are you seeing the adolescent ages? Let me share your experience.
Okay, so basically in that age group, it's a bit more difficult because the only metformin can be used quite safely. And the only 2 medications that I'm aware of, well, 3 actually, medications that I'm aware of that can be used in a pediatric, so-called pediatric age group. One, semaglutide, approved, FDA approved for childhood obesity and diabetes and so on. Sitagliptin, also approved, and liraglutide. So those are the only 3. So again, you know, lifestyle, metformin, sitagliptin is still quite reasonably priced. Once you start moving to the GLP-1s, then it becomes quite expensive. So then, you know, then a question of whether it's worth it or not. But at the end of the day, if the parents can afford it, it's worth it because you're going to prevent a lot of problems. The child is only 5, 6 years old or 10 years old. You know, if you don't treat properly, by the time they're 25, 30, they're going to be on dialysis. So you need to treat now to prevent. So again, I suppose it's a matter of affordability.
Okay, thank you. And yeah, our colleague from Cambodia, right?
Yeah, so I'm Dr. Hin Kim, I'm from Cambodia. Thank you very much for your interesting presentation. So I have 2 questions. So my first question related to the high prevalence of diabetes in Malaysia. So what is the reason behind? Is it because of the genetic or the lifestyle or ethnic or what else? And the second question, how early can we start treatment? For example, if the patient have a hemoglobin A1C between 6.5 and the patient do not want to take medication at the time of diagnosis. So how can you do the cases? Thank you.
Sorry.
Okay, first question, why is obesity becoming such a big problem in Malaysia? Sorry? High prevalence of why is it such a big problem? You know, what has happened is that it's partly lifestyle. There is a genetic element to it, of course, because in Malaysia, we have a mixed population. So we have Indians, we have Chinese, we have ethnic Malays, all of whom are generally, except for the Chinese, are predestined to develop diabetes. So the Indian population is actually very high risk of developing diabetes. The Malay population, very similar. So, you know, so that's a risk factor in itself. You know, I don't know whether you've heard about Penang or Malaysia, where I come from. You know, the food is basically available if you want 2,000 calories at 2 o'clock in the morning, it's very easy. You just go down the road, the shop's open. You can have a full 2,000, 3,000 calories very easily. So people are eating and food is cheap. So much so that it's a problem. So you can get easy calories. The other thing that has happened is that, you know, when you have a Chinese population, for example, Chinese traditionally eat very healthy, soups, vegetable, that kind of thing. Now what has happened in Malaysia is that the Chinese have adopted the Indian lifestyle. So the Chinese now like Indian food. So at 2 o'clock in the morning, the Chinese who before would be maybe eating a small meal or something, at 2 o'clock in the morning, they go out and they look for Malay food or Indian food, and they will consume 2 or 3. So that's harmonization. Everybody's eating the same bad food. So that's the other thing. And of course, it's the other things of modernization, lack of activity. People go to work, they work in the morning, they come back at night, no time for exercise, that kind of thing as well. So all of these factors have contributed. So we are like any other urban place now where our diabetes numbers are shooting through the roof. Now, what do we do at 6.5 to 7, you said? As I mentioned earlier, it really depends on what your patient wants. In an ideal world, we should intervene lifestyle changes, the diet, exercise, and those things first. And then we can use medications, as I told you from the Verify study and others. So we do intervene if patients agree for that intervention. However, a lot of Asians come in with this mindset that medication is bad for you, bad for your kidneys, bad for this, bad for that. So they don't want to take the medication. So in that situation, you try and get them to do a little bit more exercise, that kind of thing. Lately, CGM, glucose monitoring, has become very, very cheap, continuous glucose monitoring sensors. So I put a lot of my patients on the glucose monitors. There are a lot of glucose monitors coming in from China now, which are very, very cheap. So I say, look, wear one. I've got one on now. I'm beta testing one for a company. I've got one on here. So every time I eat, I look at the level and see after 2 hours, has it gone up a lot or not? So if it's gone beyond what I would expect, I would tell myself, okay, I cannot eat this. So I use this as a means of actually a learning tool to adapt my diet. So I've encouraged patients to go on this, as well as to get into some kind of regimen of walking 10,000 steps a day or whatever it is, 8 to 10,000. But it's very difficult, to convince patients to exercise regularly.
Thank you. If we have to continue, it will go on up to evening. But I'm afraid we have a constraint of time. There's going to be another symposium. So I'm afraid we have to stop here. Although we have a lot of questions to be raised and to answer. Before that, just a take-home message from this lecture, according to the Professor Mumtaz, is that we need to take into consideration of the legacy effect to get the glycemic control as early as possible and as longer as possible. And to achieve that, we need to have a selection of appropriate medication. And in this era of SGLT2 and GLP-1, still sulfonylurea, he particularly mentioned about glycoside MR is still relevant. So it can be, if we can use it very prudently, very wisely, it is still a very useful drug. And last but not the least, we should not treat diabetes alone. We should think about the comorbidities, like diabetes, hypertension, overweight, etc. And if I have to add up, now we should not approach these problems, chronic Medicare program, as a silo approach. One longitudinal vertical approach. Rather, we should approach with the vertical approach. And we should look at the problem as a syndromic approach, where cardio, renal, and metabolic syndrome. This is the current concept, where we will look into cardiac, renal, and the metabolic, like diabetes, obesity, as well as MASH, muscle D, and the MASH. So this is the current concept. So with that, I would like to congratulate Professor Mumtaz for your excellent lectures, very informative, very clear, and very vivid. And also I would like to thank the audience for your kind attention and active participation. And last but not the least, I would like to thank 𝗖𝗍 committee for organizing this lunch symposium. With that, I would like to close the section. Thank you very much for your kind attention.